into the corporate sector by joining Alcon Laboratories in the Scientific Education Division, where he is working as a surgical development consultant. Over the past 13 years, he has focused on surgical training for healthcare professionals in fecal emulsification, vitreoretinal procedures, staff training, and digital education. He has played a pivotal role in leading and executing training initiatives across India and internationally through collaborative programs between Alcon and Orbis International. His academic contributions include publications in peer-reviewed journals during his years as an optometrist. Throughout his corporate career, he has been recognized multiple times for his outstanding contributions to the ophthalmic community. Ladies and gentlemen, help me welcome Mr. Priyanshu Chandra. But before he comes, I'll introduce. Thank you
very much.
Priyanshu. Okay.
Yeah.
Before you come and take the floor, I will introduce one more person so that they can go as soon as you finish talking. I hope that is okay. So I will stop sharing and bring on another slide. Uh-oh. What slide are you seeing? Are you still seeing Mr. Priyanshu, or has my second slide come on?
Yes, I'm seeing my slide still.
Okay. Let me see. Okay, I think we're good now. So the next presenter after Mr. Priyanshu is going to be Mr. Grandson Kelvin Jere. Mr. Jere started as a clinical officer general with interest in eye care, inspired by his late lecturer, mentor, and friend, Mr. Moses Ngoi. He went to Luampa Mission Hospital for practicals as a student, where he saw a lot of eye problems in the rural community of Kauma district. While working at Luampa Mission, an eye camp by Dr. Jim Jewell and Mr. Jairus Fumpa, for some of you that may know him, Layaya, Mr. Jairus Fumpa feathered his interest in eye care. In 2008, he graduated with an advanced diploma in clinical ophthalmology as the first intake trained in Zambia and went to serve in Kaoma district. In 2009 to 2011, he went to India to study a bachelor's degree in optometry as part of faculty development in readiness for the Diploma in Optometry training program, which commenced at Chainama College of Health Sciences in 2010. In 2012, he joined Chainama College of Health Sciences as a lecturer. In 2019, he moved to Levi Mwanawasa Medical University, where he was appointed as the syndicated examinations officer. Currently, he's in his final year studying his master's in optometry. He's part of the trachoma elimination program since 2012 as a trainer of trainers and external implementation supervisor. He's also been involved in refractive error services in schools and communities countrywide through programs such as Zambia Inclusive Education Program, Seeing is Believing, the REACH Program, and School Eye Hadith Program. And he's currently the inaugural president for the Zambia Association of Optometry. Help me welcome Mr. Grandson Kelvin Jere. You're welcome, sir.
Thank you so very much.
Okay, You're welcome. Without further ado, I'll ask Mr. Priyanshu to take us through his presentation. Thank you.
Yeah, sure. Thank you very much for having me here today. And thank you, Dr. Sampa, Dr. Mumbi, for the invitation and the whole Zambian Ophthalmic Society. I consider this as great honor for me. And so without further delay, I'll start presenting my slides. Please confirm if the slides are visible. Can you please confirm once if the it's visible?
Yes, we can say it. Thank you.
Thank you. Thank you. Okay. As Dr. Mumbi told me to cover this point, like cataract surgery and refractive target, and where I'll include how to read a biometry, IEL selection, and the post-op spectacle correction. Before I start, I would like to take you through a scenario which is very simple and very obvious to understand. Is consider that you have a patient who is 65 years old, NS3 cataract with a vision of 660, and then there are two scenarios. When in one of the scenario, patient went through a phaco surgery in just 10 minutes with the best of the best machine, IOLs and all, and the ocular surface is absolutely clear. But on the final day, you found that the diffraction is -2 with minus zero point 0.5 cylindrical. Whereas on the other hand, in the second scenario, patient went through SICS, manual surgery, conjunctival chemosis, and cosmetically it was not that good. But on the final day, the patient was 6'9", and there was a very minimal refractive error. What do you think which patient will be much more happier? Now, it's very obvious to understand that the patient doesn't understand your technique, your machines, rather than they more appreciate how much they see on the very post-op. So that brings the question of how good your biometry is, because biometry is something very important that ensure your outcome on the post-op. Now, biometry is like any other terms; it's just a measurement of tissues. Whereas when you talk about ocular biometry, these are the things we basically measure. One is the corneal curvature, the axial length, the lens thickness, and the anterior chamber. And the purpose of measuring all these things is to get an IOL power accurately post-operative, pre-operative. Sorry. Now, as I said, that corneal curvature, let me start with keratometry and give you some understanding on the keratometry. The keratometry is basically the power of cornea, and it is expressed in diopter. As you know, that kerato means the cornea and the metry means the measurement. So altogether, it is the corneal measurement, and keratometry generally gives two things. One is the dioptic power, and the second thing is the curvature, which basically mostly used for the contact lens fitting. Now, how important a keratometry is. Now, just to give you an understanding that if you go wrong by one diopter, you are going to miss by one diopter in the IOL power. So it means if you are wrong by one diopter, your IOL, you are going to contribute one diopter post-operative spherical error to that patient. Now, yeah. Now, if I ask you, this is the way every keratometry should be written, if it is handwritten or if it is printed, like where you should have first the magnitude followed by the axis, then the magnitude and the axis. This is how both the eyes to be written. Now, if I ask you what is wrong with this data, probably it's difficult to tell with these numbers whether the data which is produced to you is wrong or not. That's why rather than just the data, the technique how you perform is the most important part for keratometry, because data alone cannot give you all the understanding. Just to take you through few pearls how to do a keratometry, and how you can avoid errors in keratometry. First, start with the calibration. The machine which you are using, it can be an optical method, it can be a manual method, should be calibrated frequently. Then when you are talking about manual keratometry, the eyepiece should be focused prior to the keratometry steps, because that will ensure you have a proper focused eye and then the measurement. The very important point is the pristine eye. Like whenever you are measuring keratometry, as because it's a measurement of cornea, it is very important that you do it in a pristine eye without putting any drops, particularly paracaine. Keratometry should be done before axial length measurement, uh, especially if it is an ultrasound method, or any other steps like applanation tonometry. You should do the keratometry. It is very important that you dim light the room lights, because that will help you to appreciate the Myers. Because if the Myers are not proper, that basically indicates, then there could be many reasons. The major reason is the dryness of cornea. So dim room light will help you to appreciate the Myers, how good it is. Now, very importantly, which we miss very often, that we do not make the patient sit comfortably. Now, why it is important? Because you try to understand, when you ask the patient to touch the forehead, if the forehead is not touched and you start measuring the keratometry, the eye is actually not straight to the light, and actually you are going to measure the whole paracentral area of the cornea, and the whole thing is going to be wrong. So it's very important that you make sure the patient is sitting comfortably and looking straight. Adjust the instrument height so that you can ensure that the patient is comfortable. Focus the eyepiece, as I said. Avoid squeezing, because squeezing can change or alter the corneal curvature by the lids. So, I mean, as you know that with the age, patients' type of astigmatism changes with the age because of the lead pressure. So you have to, I mean, I would say it this way, that this is the test which actually uh, demands a wide open. At the same time, you have to ask the patient to blink as well, so that you have a proper tear film. Now, the last and very important point, that you should be very much coaxial, straight to the line. Like if you see here, if you see from the below or from the top, the measurement changes. This is called parallax error. So whenever you are doing a manual keratometry, it is very important that you go to the same level of the measurement and then you read the data. Some validation criteria, and believe me, these are not done by me, and these are all published studies, and it has been shown that these are the things we should follow in the clinic, and these are the guideline when all you need to repeat. Readings are inconsistent, means you have measured twice and then you see that the readings are not matching. Repeat it. Corneal power, cornea is very flat or very steep, we should repeat it. If the corneal astigmatism between the eyes is more than 0.9, we should repeat. If the astigmatism in either of the eye, between the eyes, it's more than 2.5, we should repeat. If the corneal diameter is very flat or very steep, we should repeat. Poor Myers, as you know, that we are actually measuring on the cornea. So the Myers are the most important thing. If the Myers are poor, actually your measurement is not going to be right. Especially not, I mean, like if the patient is carrying old spectacles, ensure that the corneal cylinder is matching with the spectacle. And the last and very important point, if the patient is using contact lenses, we should ask the patient to discontinue contact lenses, especially for soft contact lenses, for at least for 1 to 2 weeks. Now, let me take you through the next measurement technique, which is A scan. Now, very importantly, this A stands for the amplitude. Amplitude means the distance of the height. That's what actually we are analyzing, how good the heights of the spikes are, and accordingly you decide whether the graphs are acceptable or not. Now, the axial length are measured in millimeters, and it is measured from anterior surface of the cornea. Remember, it is the anterior surface, not the posterior surface of the cornea. Anterior surface to the retinal layers. Now, why I'm not specifically saying which layer, that I'll take you through depending on the technique. Now, when you talk about the technique, there are majorly two techniques. One is ultrasound, and then in ultrasound there are two more technique. One is contact method, another is immersion method, and the last one is optical method. And And very surprisingly, when you miss your measurements by 1 millimeter, it will contribute to 3 diopter of error post-operatively. Even in hypermetropic eyes, it can be more than that. Now, these are the two techniques which we was talking about, the contact method and the immersion method. In contact method, you touch the cornea, the light rays, the ultrasound goes straight and come back to the probe, and that's how you get the spikes. So this comes from the cornea, this is from the lens anterior capsule, pardon me, and this is the lens posterior capsule, this is your retina, this is your retina, this is your sclera, and followed by the soft tissue. Same as the biggest advantage of immersion scan is you do not touch, which means that you do not indent, rather you stay away from the cornea, and your ultrasound goes through a medium which is water in general, and then you measure, and here you see 6 spikes, whereas you see 5 here, and the difference is you have 2 corneal spikes here in immersion scan. Now, this is a busy slide. This may look busy slide, but this is very important, that what are the things when you see a scan report, what are the things you should look at. The first thing is mode, like whether it is done in contact mode or immersion mode. That's the most important thing. Then the spikes, I mean, ideally the spikes height should be 100%. That ensure that you have a good alignment. Then the gates, whether the gates are properly placed or not, that also you should see. Then all the data, I mean, whatever you see here, all you should check individually. Like if you see anterior chamber which is very shallow, like less than 1 or around 1, which is not possible, because anterior chamber depth has a normal thickness of around 2.5 to 3.2 millimeters. So if you know the normal range, you should check whether it falls within the range. If it doesn't fall within the range, then that's an indication to repeat the scan. Then the standard deviation, it's very important that the standard deviation always lies within 0.05. If it is more than that, then we should delete the scans and then we should repeat. A constant, whichever eye value you select, we should select the same A constant, because that also can lead to error. And the target refraction, that I'll talk in subsequent slide. Always, we generally advise that you should choose the first minus instead of the plus area. Always you should choose the first minus for the patient. Now, when I talk about optical biometer, as I told you that I'll talk about this measurement techniques. When you talk about ultrasound goes up to ILM, whereas the RP, I mean the optical method goes up to the RP. So that's why optical method measures around 200 micron extra compared to ultrasound method. And now that's very important, that every IOL, whatever you select, always have two A constant. One is for ultrasound and another is for optical method. So please remember, like suppose if you're selecting one IOL with like suppose IQ lens, you have an A constant of 118.7. In ultrasound, the optical A constant will be 119.1. That, I mean, it is not always 0.4 difference. It varies lens to lens, but every IOL has two different A constant, and if you don't know, then you can lead to error. I mean, as per my experience, I have seen in many places, including when I came to work to Zambia, I had the same experience, that in many of the places we start with the optical biometer, and then there could be two scenarios. One, you do not get the axial length and you get the axial length. If you are getting the axial length, then you take the rest of the readings and then you choose the optical A constant, and then you can measure in the optical biometer itself. Now, if on the other hand, if you do not record, if you do not get the axial length, ideally then you take the patient back to ultrasound method and then you record, and Then what you do, you generally record rest of the readings from the optical biometer, because optical biometer, irrespective of the grade, it is going to give you the anterior chamber depth and the lens thickness, all the details. So, and then what I've seen that people feed them in the optical method with the A scan reading from ultrasound machine, and then we start recording. That's a wrong message, I would say, because we did not change the A constant that can lead up to zero point 0.5 to 0.75 error depending on the IOL. And there is a website ULIB. If you go to this website, you can find all of your IOL optical and ultrasound A constant. So that's another way of finding out what exactly A constant you should start selecting. But ideally, if you are measuring the axial length from ultrasound method, you should consider ultrasound A constant. Now, few pulse is immersion is the gold standard. Calibration, as I said before, a 5 spike of the good amplitude. The gain should be of the lowest level in the beginning. Then we should gradually increase. Take care of axial alignment, and do not push too hard, because that can lead to myopic error. The validation criteria, the standard deviation should be, as I said, should be lowest. Do not put any drops before you do. Any eye which is short and long, you should remeasure, always measure both eyes. Repeat if the axial length difference between eyes are different by around zero point 0.2 and more than that, we should repeat. These are the guidelines are there. Now something about formula, and I'm sure whatever formula you are using, this is the most widely used formula, which is SRKT, but it has a limitation of measuring, giving you IL power accurately within this axial length 22 to 24.5. The ideal way is to use Barrett Universal 2 formula, which is readily available online. If you go to website and start typing Barrett Universal 2, you'll find the page and you just enter the data and you're good to go. And that's what the thing. And rest of the formula, either it is paid or not available, so it is not easy to use, whereas Barrett is very easily available online. You just need to have all the data. And I generally, wherever I go, I try to implement that we start using Barrett. So this is a study by Dr. Douglas Koch, published in JCRS, and it also has shown that Barrett is perfect. And there are multiple studies which has shown properly that the Barrett is the answer for any grade of lens. Now, something about the IL selection. Now, when I talk about IL selection, the decision making should be a common. It's a common judgment between the surgeon and the patient, because the different patients has different requirement, different expectations, comorbidities, and ocular healths. We should always select the IOL considering all these factors. Now, just small guideline, I would say that if the patient doesn't have a expectation of wearing glasses, monofocal is good enough. Depending on the requirement, like if the patient wants to be glass free but patient has a habit of going out driving, then EDOF, extended depth of focus lenses are the good choices. uh, Maximum spectacle independence gives the trifocal, but there is always a chance of fatigue phenomena. So patient who stays inside doesn't have I mean like much of driving, then they are fit for trifocal. Significant astigmatism, I would say it is very important nowadays that you correct your astigmatism by either by the mean of lens, or by with the help of incision. We can start try neutralizing astigmatism to a certain level. If the patient is having a history of refractive error, myopia, it is always advisable that you give them aspheric lenses to negate that spherical aberration. Any ocular pathology, either monofocal or EDOF lenses are the choice, should be the choice. So it should be always aspheric. Aspheric gives the best contrast and clarity. Target refraction, it is a spherical equivalent. So if you follow this, that this patient is having 2.5, and if you choose an 18 diopter, which will give you a 0.26, don't consider that this is the spherical power or refraction the patient is going to get. It is actually the spherical equivalent, and if you see the formula, it is actually sphere and half of the cylinder, and here you can find out how this spherical equivalent came. So the point is, it is basically a glimpse what spherical and astigmatism patient is going to get. Always choose the first minus for the eye. Like if you see here in this column, the patient is having first minus with 18.5, and if you go to 18, the patient is going to be hypermetropic postoperatively, which shouldn't be the choice of your eye well. It should be always first minus. So, and the last very important thing, is the cost. Always consider, ask the patient's need. Cost is a very important thing. Patient's need needs to be understood before you select the IOL for the patient. The last slide for me, the refraction part, it starts before surgery. That always target, select the target accordingly, whichever your preference, and then it is shown that the incision gets healed by around 4 to 6 weeks, which is a month of after surgery. So give your refraction after a month. It's very important. I have seen many times when during my optometry day, like if the patient is one-eyed, it is very important that you give them mobility by giving a temporary glass. It may cost them something, but it is not less than anything very important for them, because they are going to get some amount of vision, and then you can give a final refraction later on. The need, the near distance is not same for every patient. So it's a very customized thing. You ask the patient to hold the near chart as per their convenient, their professional demand, and you can start adding power. It's not that you should start exactly starting from 2.5 in pseudophakic cases or 3. It should be a customized approach. Like depending, as I said, that there are a profession which needs intermittent glasses where you may need lesser addition. The last point is, it is very important that if the distance power is good, there is no power, then you can ask the patient not to wear glasses, rather only for near glasses. Talk to your patient before and after. That's very important. Just to check, as our last speaker also emphasized that, please check patient satisfaction. That's very important for all of us. Now, just take home some take home message. Accurate biometry is very important. IL selection should be a choice, should be between the surgeon and the patient. Post-operative spectacle, it's very much customized thing. Talk to patient, and then you understand. And the last and very important point I wanted to emphasize, that any discrepancy you see between your results and your target should be reviewed thoroughly to understand where exactly it went wrong, and then probably you can go ahead. This is a platform, Alcon Experience Academy. You can, if you can go back and you can log in. This is the area where you can find out ways to register yourself, and you'll find out contact lenses, biometry, surgical related for everyone, like from starting from optometrists to ophthalmologists to ophthalmic staffs. We have content for everyone. You can go back and check that if it works. And thank you. These are some of my memories with these wonderful people. Thank you very much for having me. I hope you enjoyed. Dr. Sampa, over to you. Yeah.
Thank you. Thank you so much, Mr. Priyanshu, for a very thorough presentation. I loved your introduction when you said one surgeon can do phaco, another one does M6, but the patient does not care how sophisticated the surgery is. What they care about is how they can see after the procedure. Thank you. Thank you so much.
Thank you very much. Yeah.
Yes, I hope you've seen those hands. People are clapping. They're happy and they appreciate
Yeah.
you.
Yeah. Thank you. That makes my day. Thank you very much.
Okay, thank you. Okay, at this point, I'll ask Mr. Jere to take the floor and give his presentation.
Thank you very much. Good evening. Let me share the slide. Please allow me to share.
You can share, sir.
Is it clear?
Yeah, it is visible, but there are two gray scales on your screen. Just remove them so that you see the whole screen.
All right. Let me just
Yeah.
let me just you're saying there are too many grays? Let me just
Show mode now.
hello?
It's correct now. You can make it full screen. Yeah. No, it's correct. You
Okay.
can make it full screen. Yeah.
Okay. Is it okay like this?
No.
Okay, probably. What about now?
It's perfect. Yeah.
All right. I'll not go to the full screen. I'll use this if we can all read. Sure. Thanks so very much, and good evening to everyone. Those from Zambia, India, Zimbabwe, Mozambique. Thank you very much for being with us during this World Optometry Week. And thanks to Zambia Ophthalmological Society for putting optometry on the spotlight, and that is greatly appreciated. So I'll be talking to the theme of this year and looking at Zambian perspective. We are aware that the World Optometry Day is held annually on March 23rd to celebrate the optometry profession's vital role in global eye health while highlighting how optometrists worldwide are expanding access to eye care as a fundamental human right. And this is not exception to Zambia. This year we celebrate World Optometry Week from March 22nd to 28th. 2026 with the theme, A Shared Vision, Collaboration in Global Eye Care, as demonstrated by what we're doing today. So global eye health challenges, according to the 2019 World Report on Vision, global population expansion, demographic aging, and accelerating urbanization are key factors placing growing pressure on healthcare systems, particularly in the delivery of sustainable eye care services. The report underscores that the rising demand for vision and eye health care worldwide exceeds the capacity of any single professional grouping, necessitating collaborative and integrated approaches across all disciplines. There should be a correct professional mix. The message from the World Council of Optometry President, Dr. St. Tromans, said that collaboration would shape the future of eye care, emphasizing that optometrists play a vital role as primary providers of vision and eye health services and have the greatest impact when they work in partnership with others across the healthcare system. She added that the theme reflects the evolving nature of eye care and a shared responsibility to ensure that no one is left behind. And the no one is left behind resonates very well with a national development plan for Zambia. So Zambia has not been spared from the global eye healthcare challenges. The 2026 World Optometry Week theme is highly relevant to Zambia's current health landscape and reinforces the country's commitment to strengthening equitable and accessible eye care services. It echoes the call by the World Health Organization for integrated, people community-centered eye care, an approach that is particularly important in addressing Zambia's disparities in eye health service delivery between urban centers and rural communities. What is people-centered eye health care services? And we know that for eye health care services to be successful, there should be a buy-in from the communities. Because if there's no community participation, most eye health intervention measures cannot succeed. So putting people at the center of eye care means more than service provision. It requires bringing care closer to the communities. And we know how difficult it is for patients in certain rural areas of Zambia to reach healthcare providers in selected areas where we have the service. So this includes strengthening primary healthcare systems so that basic eye services are available at local health facilities, improving referral pathways, and expanding outreach programs to underserved areas. It also means prioritizing affordability and awareness, ensuring that preventable and treatable conditions such as glaucoma, refractive errors, and cataracts are identified early and managed effectively. So collaboration is central to achieving these goals. Stronger partnerships between the Ministry of Health, professional bodies like the Zambia Ophthalmological Society, the Zambia Association of Optometry, training institutions like Leviman National Medical University in Zambia, and cooperating partners in eye health are essential to addressing workforce shortages, improving infrastructure, and enhancing service delivery. Community structures, including schools, traditional leaders, and local organizations, also play a vital role in promoting eye health and encouraging timely care-seeking behavior. Collaboration, the impact on our profession. Without the input of the government of the Republic of Zambia, other high health colleagues, the ophthalmologists, ophthalmic officers and nurses, general health practitioners, support staff, community health workers, and cooperating partners wouldn't have been what we are today. We appreciate all of you for making our work easier and to be recognized in our work in Zambia. Looking ahead, Zambia's progress in eye health will depend on deliberate, coordinated action, aligning national strategies with global frameworks, investing in human resources for eye health, and fostering cross-sector collaboration will be key to achieving sustainable impact. Ultimately, by placing people and partnerships at the center of eye care, Zambia can significantly reduce avoidable visual impairment and move closer to universal access to quality eye health services. A shared vision, collaboration in global eye health. As optometrists, we celebrate this week with all those who have made us to be what we are today. Let us continue with a shared vision as we collaborate in global and Zambian eye health. Happy World Optometry Week, and God bless you all. Thank you.
Thank you so much, Mr. President. That was the president of Zambia Optometry Association. Indeed, putting partners and collaboration at the center of eye health is how we win the fight against blindness. At this point, I will invite questions for the three speakers that we've had before I introduce more speakers. Do we have any questions? You can raise your hand if you have a question for any of the three speakers. Any questions from the audience? I can't see any hands. If you have a question, please unmute yourself and ask. Any questions? Going once? Everything was clear. Anyone with a clarification? I don't know if I should be happy or worried. Are people following the discussion?
Everything was wonderful, enjoying the discussion, hoping for more interactions like this. Thank you.
Okay, great. Thank you for that feedback.
My question is to Mr. Jere. Good evening. This is Dr. Tembo from UTHI Hospital.
Good evening, Doc. Thank you.
Yes, I wanted to find out what steps are you taking for the members, for the optometrists in Zambia, to help them undertake fellowships. You know, we have general optometrists, optometry technologists, but are we planning for them to undergo further training so that they subspecialize? Thank you.
Thank you very much, Doc. I think that's a very good question. We are in the process working with other partners with the Africa Council of Optometry, and we are going ahead in trying to make sure that we collaborate and establish linkages for fellowships in places like Nigeria, who are quite advanced with fellowships. They have been in this industry for a long time, and South Africa. And we hope to work with other institutions with our linkages in India. That is where we have connections. But before we really strengthen some of those partnerships, we're in the process of registering with the Health Professions Council of Zambia as a CPD provider. So we are working on those measures to try and open education opportunities for our members. Thank you.
Thank you so much for the question, Dr. Tembo. Do we have any other questions?
Good evening. Oh, okay.
Okay, Dr. Mumbi, you can go, and then the other person, I didn't get the name, sorry, can go after you.
Just a quick one, Priyansh, thank you very much. This is Dr. Mumbi from Lusaka Hospital. I just wanted a clarification. Sometimes we do have confusion when trying to select the air constant to use. If, for example, you are using immersion scan, which air constant do you take? Do you take the optical or do you take the ultrasound one?
So immersions can also done through an ultrasound method. So please consider ultrasound A constant for immersion and contact both the techniques.
Okay, thank you very much. And to Mr. Jere, just a quick one. I think on a good note, Sakai Hospital is considering to start doing some fellowships in optometry. So I think there's good news nearby. I'm sure Bibek will one day talk about that.
Thank you very much, Dr. Mumbi. We appreciate the efforts Osaka Eye Hospital is doing in making sure that optometrists have opportunities in learning advancing services in optometry. Thank you.
Okay, thank you so much. I think that will close the Q&A for now. And I'll go on to introduce two more speakers, and they will take the floor, and then we'll have more Q&A. So our next speaker is Mr. Nikesh Kangin. I hope I'm pronouncing that right. He pursued his bachelor's degree. Okay, great. He pursued his bachelor's degree in optometry from the College of Optometry and Ophthalmic Science, Nashik, affiliated with Sunrise University, Awar, Rajasthan. After graduation, he gained clinical experience working as a consultant optometrist at a comprehensive eye clinic in Jauna for a year. His growing interest in contact lenses led him to pursue a postgraduate diploma in optometry and vision sciences, specializing in the anterior segment and contact lenses at the Brian Horden Institute of Optometry and Vision Sciences, LV Prasad Eye Institute in Hyderabad. During his postgraduate training, Nikesh research work on myopia and its management strategies, with a particular focus on the efficacy of various myopia control interventions. His passion for this field motivated him to actively contribute to myopia management. Currently, he is a consultant optometrist at the Info Myopia Center, LV Prasad, where he continues to expand his expertise in myopia control and patient care while actively pursuing research. Ladies and gentlemen, a big hand for Mr. Nikesh. I don't see the hands.
Thank you so much, ma'am.
I'm not seeing the emojis. I want to see the hands. Okay, and then the next, okay, good. I see that, Priyanshu. Thank you so much. The next, my screen is frozen. Okay, the next presenter is Miss Esnat Kapatamoyo. She's an optometrist and lecturer at Levi Mwanawasa Medical University in Lusaka. She holds a Master of Public Health in Community Eye Health and has further training in teaching methodology, leadership, and management for strengthening eye health systems. She's actively involved in training the next generation of competent optometrists, strengthening clinical education and quality assurance in training sites. She's involved in advancing public health ophthalmology, and she promotes equitable access to eye care services across Zambia. A big hand for Miss Esnat Kapatamoyo. Okay, are the hands coming? I hope the hands are coming. I need the hands. Let's encourage our speakers. Okay, thank you. And at this point, I'll ask Mr. Nikesh to take the floor and take us through the presentation. Thank you.
Yeah, can you see my slides?
It's about to start sharing. Okay, great. We can see your slides now.
Yeah. Sorry, my camera is not working. Thank you so much for having me here, and special thanks to Dr. Mumba for this invitation and of the Zambia Ophthalmology Society. So I think we are running late, so I'll just quickly talk on myopia, covering this all session. Myopia specifically, I'm talking about prevalence from global perspective, then Zambia, India, and a couple of slides on risk factors, and then management strategies, what we observe, and then cases like that. So the objective, I'll talk prevalence, risk factors, couple of evidence slides on evidence and management guideline, what we follow at Info Myopia Center, and a couple of cases I'll take you through which we have managed. So if we talk about global prevalence of myopia, definitely it's going increasing every day and every years we can see. And this picture shows in each continent the prevalence is increasing. And recently when I was looking for Zambia prevalence, a couple of studies was indicating specifically from student group, like from the age group of student and universities are going to increase and progressing, and it's recording up to 60, close to 60%. Globally, definitely it's going to increase and the burden is there. So we all know the study which was by Brian Holden, which indicated by 2050, 5 billion people will be myopic and about 1 billion will be high myopic, and that 1 billion will be at risk of sight-threatening complication, which may be retinal detachment, glaucoma, cataract, or anything else as well. If we talk about African scenario, this is picture which shows in African regions the number of studies which are done in relation to document the prevalence of myopia or studies in relation to myopia. Specifically, there are states where different generally studies are done, but in specific Zambia, population-based study is lacking as of now. Couple of studies are there which was on the student group, which indicated the prevalence. If I specifically say the prevalence in the student group, which was about 2.2%, which is increasing. Previously, it was very minimal. Then if you look at the university based, it's going to be about around 56% in Zambia. Then if you look at Indian data is similar trend following to global trend, which indicated by this study from the Dr. Pawan's group, around 48%, 48% prevalence will be expected by 2050, and presently probably we are looking at present time in 2025, which is around 25 to 30% close to. If you look at the risk factors, myopia is a multifactorial disease now we can say, and starting from the outdoor activities, scientific, diet related, near work related, electronic device related, health, sleep cycle related. Now studies coming up in relation to gut microbes, liver function tests, psychological state, air pollution. So it is completely probably most of the things which we may not known as well in the field of myopia. So it is a multifactorial in nature. So now there are multiple evidence and n number of studies look for controlling myopia. If we talk about low myopia, there are n number of studies which indicate different interventions are working for myopia control. Now this is a living systematic review which indicate there are multiple options are used and slow down myopia. And on higher side, probably higher concentration of atropine works better. But again, different option considering ortho-K, peripheral defocus, low dose atropine, multifocal contact lens are also used, and they shows good outcome. Single vision, if you look at the bottom, RGP lenses, which does not work to control myopia. That's true. Single vision doesn't help to control myopia. Outdoor activities generally, which are studied eventually and much wider range, sunlight activity, the mechanisms probably will be higher ambient light, which gives uniform dioptric field, can relax accommodation, decrease pupil size, which can increase the depth of focus, exposure to different spectral light levels, and that can release dopamine secretion in the body as well as retinal level. That's how it can act as a protective mechanism for myopia. So if you look at studies in high myopia, low myopia, we have a number of study, but in high myopia, very limited study. If you cross -6, so what options we have to control myopia? Probably around 10 to 12 studies which indicate atropine most commonly used and their efficacy which stated. Then we have ortho-K, which was used partially corrected, ortho-K, which was also studied. Then on the specific defocus lenses or bifocal is not studied yet in high myopia group as well. But there are research which are coming up in high myopia group as well. So now we have different, we have efficacy ranges, the options. So what should be the guideline to manage myopia? What we follow at Info Myopia Center at LV Prasad Eye Institute. So impact guideline. Impact is an acronym which stands for I. I stands for identify true axial myopes, which indicates rule out other forms of myopia. We want true axial myopia for myopia management. So rule out refractive myopia, curvatural myopia, positional myopia, anything we want to rule out. So how we can rule out? By doing biometry, looking at the axial length. Then we need to map the risk factors. What are the risk factors? Usually we look, as you have seen that slide, age, refraction, axial length, near work, outdoor, parental myopia, accommodative status, peripheral diffraction. These are all the risk factors which we usually map, and based on that we will see. Then third one is pick the progressive myopia, whether the individual is progressing or not. We don't treat myopia. We need to see whether the progression is there or not, and what's the rate of progression. Then only we will decide any appropriate myopia control intervention, which is A stands for. Then at last, C comes for consult. We need to educate the parents as this epidemic coming up about the options, how we can manage, what preventionary actions they need to take. We need to counsel if myopia is still progressing with one therapy, then probably we want to combine. That's combination therapy. We want to monitor probably every 6 monthly kind of thing, depend on the rate of progression. And at the last, when we should taper the intervention, probably at late teenager, where we look couple of years, at least two years stable back-to-back reading of axial length and power. That's where we look to stop this. Now, moving on to myopia control interventions, what are available across globe. So probably there are multiple sort of interventions starting from behavioral modification, which include sunlight exposure, which mostly recommendable 2 hours outdoor activity a day. Then comes with optical intervention, in which bifocal or progressive addition lenses, defocus spectacle. There are different brands which have providing different kind of design of defocus glasses. Then comes contact lens. There are different brands, daytime, nighttime, wear contact lens, wear multifocal contact lens, EDOF contact lens, or orthokeratology. If one thing is not working, then combination of multiple intervention like optical plus pharmacological. And now the evidence which are coming up related to partial correction as well in severe or high myopes above minus probably 10 or 12, what we have, so we can give partially correct as well. Most of the options which we give nowadays in high myopia. So in defocus glasses, what's the different technology? Why single vision lenses are not working, and why defocus or peripheral defocus lenses are working better to control myopia? So this is uncorrected myopic eye. You can see where this center, which shows generally, in center, which you can see the myopic eye, where rays are focusing in front, and in paracentral rays where focusing behind the retina, which generally gives signals to the brain to increase eyeball size. If you give single vision, central rays which are correcting, which gives clear vision, but paracentral rays which are still more hyperopic, which indicates sending the signals to the brain, which can trigger to increase power. Now, what happens if we give peripheral defocus spectacle or contact lens? That same rays which are focusing behind, which comes in front. So that's how this technology works in form of peripheral defocus contact lens or defocus glasses or ortho-K. Now coming on to the cases, I'll talk about 2-3 cases where we manage. So this is a 10 years young child which came to us at info myopia with a frequent increment in spectacle power in February 2024. This case I have selected specifically because I have seen recently in last month. So if we look, we have done a detailed assessment in this, where we looked at the age of onset of myopia, where 7 years of age he started using glasses. Then he was using 3 years, and at present is 10 years old. Time outdoor was very limited, about 10 to 15 minutes. He was indoor centric in routine. Near work about 9 hours, including school and tuitions as well as gadgets. Refractive error was minus 3.25 with minus 1.75 at 180 degree for right eye, and left eye minus 3.5 with minus 2.25, 180. So cover test was also performed to look for any phoria. So for distance and near, it was ortho. Then there was increment in power about 1 diopter in both the eyes, and axial length about 0.54 mm and 0.49 mm in respect to right and left eye. Accommodative status was also looked at, so which was within normal limit. Peripheral diffraction was also done, which indicate about 1.50 diopter relative peripheral hyperopia was there. So considering this risk factors, increase in about 1 diopter, there was about 500 microns changes in axial length in just 10 months. And relative peripheral hyperopia about 1.5 diopter, we started with peripheral defocus spectacle for this individual. And you can see in this slide, in every follow-up, we have given around 1.5 years follow-up. So at first, when there was progression about 500 microns change in axial and then 1 diopter change in refractive error. So we started on peripheral defocus. We asked because of this progression, that much of progression, we called him in 6 months. Then there is no change with peripheral defocus spectacles. Okay, we said we will monitor probably in 1 year. Let's see. And still there is no change. And recent visit as well, there was no change in refractive error as well as axial. So it showed this peripheral defocus glasses works better in this case where relative peripheral hyperopia was triggering sign. Now moving on to the second case. So this is 8 years young child who came with same complaint, frequent change in Jan 2024. So detail history, again, we look for age of onset, how many years he is using glasses. Outdoor was very limited, again 30 minutes, indoor was very high, around 9 hours including school and gadgets. Refractive error was minus 9.5 for right eye with 0.75 diopter cylinder at 170 and left eye was minus 0.75 diopter. So it was high myopia, very high, and anisometropic. Refractive error was also there. So cover test was ortho. There was 0.50 diopter change in refractive error, but the axial length, if you look at, very drastic change, which was about 700 microns, 0.74 mm in right eye and 0.75 mm in left eye. Accommodative status was checked over the best corrected refractive, final refractive error, which was about 0.75, which is normal. But relative peripheral refraction was done, which indicates in right eye about 2.25 diopter of relative peripheral hyperopia. So that's where we come up, okay. So for this case specifically, unilateral high myopia, left eye is low myopia, right eye is very high myopia. What should be the option? Then we come up with center distance multifocal contact lens to manage the myopia as well as to overcome anisometropic cornea as well. So how multifocal contact lens works? So considering the design, center distance design, center rays give the clear vision. Paracentral, which is the near vision zone, which create relative peripheral myopic defocus at the retinal level. So it will change the signal which was going to trigger to increase power. So now in this case as well, you can see follow-up axial and changes. Initially, when we started, there was change. We started with multifocal. In second visit, in just 8 months, still the changes was there, about 0.17 and 0.07. So we said, okay, wait and see. Again, when he came after 5 months, there was change about 0.46 mm. So we said, okay, younger age, there was drastic changes. So we should start with combination therapy. So we added on atropine 0.01% on this February 2025. Again, we said because of this higher changes, we want to see him in 5 months. So we called him 5 months. Then there were very little changes. So we asked to continue same therapy, combination intervention, multifocal with atropine. And in very recent visit, November 2025, there were very minimal changes and his refractive error was minus 11 and with 0.5, 70 and left eye minus 0.75, which was stable. In right eye in between, it was changed. So this was second case. Then coming off to third case, which was severe myopia about 19 and 18 diopter in right eye, 19 diopter, left eye 18 diopter. So we managed this case with multifocal contact lens. We know generally multifocal contact lens comes up to minus 10 diopter. So residual was given with single vision spectacle. Patient was happy. So if you see in first visit in this graph, 17 April, that's where the patient was came to LV Prasada Institute at first. In COVID, he skipped his follow-up in 2021 when he reported to Myopia clinic in Jan 2021. That's where we looked for progression. There was drastic change, about 5 diopter change in refractive error and about 1.6 diopter, 1.6 mm change in axial length of both eyes close to. So that's very drastic in about 3 years. So that's where we look for progression, and then we sort of started on multifocal contact lens to manage this, considering the option of relative as a relative peripheral hyperopia and other risk factors. And if you see in follow-ups, in every time there was very minimal changes and it was very well stable, and we have written this case report as well. Now at the end, So myopia management is not just term, it indicate it a broader term. Under that, multiple things comes with like prevention, education, awareness, risk assessment, myopia control, myopia correction is different, myopia control is different. We need to monitor refraction axial length in every time for every individual to manage myopia. In summary, I want to say myopia management is beyond single vision correction. Myopia is a multifactorial disease now we can say, and which don't have any single risk factors, which is multifactorial. Then we need a standard guideline probably to manage myopia, so which we use impact guideline, which is the way forward for practitioners. So one size does not fit for all, so we need a personalized myopia care as well. And this is one statement which I want to say: once a myope is a lifetime myope. And thank you. I want to thank my team who helped me, and thank you. I'm happy to take any questions.
Wow, thank you so much, Mr. Nikesh. Such a loaded presentation with so many take-home messages. And I know that people appreciate. I can see those hands going up and everybody is happy. And I know they have questions for you, but I will ask them to keep them for now, in the interest of time. And I'll ask Ms. Esnat to do her presentation. And I'll introduce Mr. Bibek shortly after Ms. Esnat finishes so that we can have a Q&A for the three presentations, and then we'll close. Ms. Esnat, please.
Okay. Good evening, good morning, good afternoon. I know we're in different parts of the world, so are probably in different time zones. So just allow me to share my screen.
You can go ahead and share.
Okay, I'm having a bit of a challenge. Perhaps you could allow the next speaker to go ahead while I just fix the technical issue I'm having.
Okay, noted. I will introduce our next speaker while Ms. Esnat works on her technical issues. Okay, so our next speaker is Mr. Bibek. Most of us have met him, we've interacted with him. He obtained his bachelor degree in optometry from Kolkata, India. He did his postgraduate diploma in optometry and vision sciences, focusing on pediatric, binocular vision, and neurooptometry from LV Prasad Eye Institute in Hyderabad, India. He is an associate member of International Association of Contact Lenses Educators and is a consultant optometrist and HOD of optometry at Lusaka Eye Hospital. Mr. Bibek, you are welcome and we are ready for your presentation.
Hello, thank you for the nice introduction. Just allow me to share my slides and then I'll switch on my video as well.
You can go ahead and share, sir.
Just 1 minute. I'm trying to share it now. Is my slides visible?
Not yet.
Can you see my slides now?
No.
Is it visible now?
No, it's not.
Okay, is it visible now? Can you see my screen?
No, we can't see your screen.
Okay, can you see my screen now?
Yes.
Okay, thank you. Okay, so as I'm trying to see if I can switch on my video, but still I'll start my presentation. Good evening, everyone. Thank you for the introduction. I really appreciate Josh for giving me the opportunity to speak about the keratoconus disease in the irregular corneas. Today, I'll be discussing about keratoconus diagnosis in the irregular corneas. This condition is specifically important because it affects young patients and can significantly reduce vision if not detected earlier. However, with early diagnosis and proper optical management, we can greatly improve vision outcomes and delay surgical interventions. By the end of the session, you will be able to understand the disease, identify clinical signs, interpret topography, and choose appropriate management in keratoconus cases. So, what keratoconus is. For that one, we need to understand that what is the basic of keratoconus. So let us begin with the basic. The cornea is a transparent avascular dome-shaped structure forming the anterior surface of the eye, which contributes nearly 2/3 of the total refractive power. And for clear vision, the cornea must maintain a smooth and regular curvature. In keratoconus, there is a progressive thinning of the corneal stroma, leading to forward protrusion into a cone-like shape. In the cone-like shape, this causes irregular astigmatism and high-order aberration, resulting in distorted and blurred vision. It is a progressive, non-inflammatory disease condition, usually bilateral. Sometimes it can be asymmetrical as well. If a patient has frequent spectacle changes, like this is a clinical insight. Basically, when you see a patient complains for frequent change in the spectacle prescription, which is unexplained, definitely you should always suspect for keratoconus. Epidemiology wise, if you see, 1 out of 2,000 is a general prevalence, which was in 1986. And then the age group, it ranges between 10 to 25 years of age. Keratoconus typically begins during the adult or early adulthood, and may progress until the 3rd or 4th decade of the life. With advancement in diagnostic technology, like the current diagnostic tools which is available, it really helps corneal topography, and detection rate has increased significantly. Early detection is very crucial because procedure like corneal collagen cross-linking can stop the disease progression, or it can delay the progression in time. So in classification for the keratoconus, we have different types of classification available. These are some of the classifications which I'm going to submit, which can give you the basic idea and how to detect keratoconus in the earlier and the advanced stage. So based on the care readings, we have mild, moderate, and severe. You can see it depends on the dioptric power. So if it is less than 48 diopters, we can say that it is mild in the stage. If it's between 48 to 54 diopter, we can say it's in the moderate stage. And if it is greater than 54 diopter, then it is severe stage. Based on the morphology, we have 3 different types as well. One is nipple cone, the other one is oval shaped cone, and global shaped cone. So in these 3, it definitely, if you are seeing the numbers which are written in millimeters, basically it shows how many millimeters the corneal zone is affected. So in the nipple cone, mostly it is usually in the central of 4 millimeter zone. In the oval shape, usually it's between 5 to 6 millimeter zone. And in the global shape, it is between greater than 6 millimeter zone. And then we have Amsler Crimich classification, which has 4 stages, which basically this classification systems include refractive error based on keratometry, corneal thickness, and scarring. It also helps in staging keratoconus and monitoring the disease progression. Clinically, this classification is very useful if in deciding the treatment and time intervention. So etiology of the keratoconus, usually keratoconus has a multifactorial etiology. The most important and risk factor is eye rubbing, which can cause repeated mechanical trauma and weakness corneal collagen. There is a strong association with allergic conditions such as allergic conjunctivitis, eczema, and hay fever. Genetic predispositions is also seen, and systematic association include connective tissue disorder. In the etiology, the most important and the key factor is always ask about eye rubbing. It is a very crucial clinical clue that you'll be able to identify if the child or any adult who has a frequent habit of rubbing of their eyes. There is more likely that you can suspect that there could be some changes in the corneal curvature. Pathophysiology-wise, keratoconus is essentially a biochemical failure of the cornea. This is a stromal thinning due to collagen loss, along with the breaks in Bowman's layer. Iron deposition forms the Fletcher's ring, and these changes results in weakened cornea that bulges forwards under the intraocular pressure. So, like a woolen balloon, walls bulging outward, you can analyze it, and you can see in the picture as well, which I have shown, the way the cornea is bulging. Then the common symptoms you can see in the images which I have. When you have astigmatism, how you can see the image, and when you don't have the astigmatism, how clearly you can view it. So that is the difference in the images which I have shown it here. In the early stages, blurred vision, mild distortion, and frequent spectacle changes. In the advanced stages, you will see severe distortion, glare, halos, and poor contrast sensitivity. Eventually, even best corrected vision is reduced. So that means sometimes if you correct a person or a patient with glasses, it might not help them to see clearly when the curvatures are not good in shape. So frequent prescription changes should raise a suspicion that patient can have keratoconus, and this could also indicate that what are the investigation you are supposed to send to the patient for the management. Similarly, these are the common signs. You can see the videos in the second. You can see how the seizure reflex. Let me show you one more time. If you see the image A, that video actually showing the seizures reflex. Yeah, I hope everyone is able to see the video. This is how the seizures reflex looks like. Some of the important clinical signs are seizures reflex. Usually you will see it in the retinoscope when you are performing retinoscope. Then Munson sign, residue sign, then central thinning of the cornea, Fletcher's ring, oil droplet sign in the ophthalmoscope, and very early stages you can see prominent corneal nerves and box tri. These are the common signs which you are going to see. These signs are very useful in diagnosis, especially when imaging is not available at your facility. And currently, we in Zambia, we don't have in many of the hospital or clinical facilities, we don't have all the instrument. And considering that one, I think these clinical signs are very important to detect the keratoconus. So I hope the images which I have shown in my slides will be really helpful for someone who really wants to diagnose keratoconus. Then these are the common type pattern of the keratoconus. You can see round shape, usually oval shape, superior stiffening, inferior stiffening, irregular thinning, and then symmetry, bow tie with skewed radial axis, asymmetrical bow tie with inferior stiffening. These are some of the pattern which you will see in the topography images, which really helps you to understand whether the patient has any early changes or any advanced changes in the cornea. This is the topography map, which usually this is taken from a pentacam imaging system. This is just to give the glimpse about how you can identify the stiffening in the cornea. So there are like color coding. If you see if the blue and green, which represents flatter areas, and yellow, orange, and red represents stiffer areas. So simply, if you want to remember it as blue means flat and red means stiff. Normal cornea shows a symmetrical bow tie pattern. That is what you have to understand. If you go to the slide and if you see the last of the image in this particular slide, you can see the symmetrical bow tie pattern, which usually you will see in normal corneas. Just try to avoid this red image. Usually you'll see very symmetrical bow tie pattern. Then in the keratoconus, we see inferior stiffening, asymmetrical bow tie pattern, and localized red zone. So these are the indication what you are going to see in the pentacam map. Apart from that, one more tip I want to give all of the listeners who are there is like, if you want to identify a keratoconus in the early stage or whether it is in the latter stage, if you go through the axial map, the first map which is being shown in this slide, that is the axial map. If you see this, the line which is drawn, which I'm sure if everyone is able to see my slides, you can read some numbers are written there, but definitely you can see the skewing of the axis. If the axis is skewed above more than 20 degrees, that means, that indicates that the patient definitely has a keratoconus. So always pay attention to the axis skewing in the axial map. That is the early indication. You don't have to even go through all the indication of elevation of or corneal thickness. If you just know that if there is a skewing by 20 degree, that means patient can have the keratoconus. Apart from that, and when you are analyzing it, always check the location, symmetry, and intensity. Like types of map, if you have to see in pentacam, that is axial map, tangential, and elevation map. With tangential and elevation begins more sensitive for earlier disease. Clinical importance are like topography helps you to diagnose earlier, and it helps you to monitor and also allow for the contact lens fitting. Missing keratoconus can lead to wrong prescriptions as well. So if we have to understand about the goals of the optical treatment, you need to know, basically we have to improve the visual quality, because the visual quality is very poor in keratoconus cases because of the irregular corneas or change in the curvature of the cornea. So considering that, improving the visual acuity by correcting optical irregularities and improving the image quality, that really can improve the visual quality. Then also to enhance the comfort, patient compliance depends on the comfort, especially for long-term use. So in second part of my slide, in the same one, you can see that soft spectacle and soft contact lenses. Spectacle are useful in earlier stages, basically to improve the vision. Soft contact lens, usually soft toric lenses, can some extent help the person to have some clarity in the vision if in the very early stages, or customized soft contact lenses. Then the limitation for these two are ineffective in advanced stages and cannot fully corrected in irregular astigmatisms. And if the best solution wise, if you ask me, it is going to be a rigid or a specialty contact lenses. This is the contact lens which is gold standard, I can say, which provides very smooth refractive surface and allow patient to see clearly, excellent vision with effective correction, I can say. Some specialties lenses are also available, like scleral lenses, hybrid lenses, and rose-K lenses. These are the lenses used in advanced keratoconus cases. So in summary, in early cases, you can use a spectacle. In moderate cases, you can have choice for RGP lenses, and in advanced cases, you can have the option for either a rose-K lenses or a scleral lenses. Scleral lenses basically gives better comfort because of vault over cornea, provides fluid reservoir, and it gives excellent comfort. In hybrid lenses, basically it's combined with RGP, clarity with soft lens comfort. So that can also help sometime. In total, I can say that if you go for the proper management system-wise, to conclude, the keratoconus is a progressive condition requiring early diagnosis and proper management. So this is how this flow chart which you are seeing, it basically allow you to help in which case the contact lens is going to be better option, and in which case the surgical options are much better. Basically, in the earlier stages of the keratoconus cases, the contact lens, even in the advanced stages, it can help. But there are certain cases like when the corneal hydropsis and if the advancement of the cornea curvature changes, then definitely the surgical options are required. So with timely intervention and appropriate optical correction, we can significantly improve the patient outcome. As clinician, our responsibility is to detect early, educate patient, and provide the best possible care. A second opinion is always not a doubt. It's a commitment to give the patient the best care. So with this, I'll want to conclude. And I hope I have given the brief introduction about the contact lens, which everyone can understand about the basic sign and symptoms and how we can detect the contact lenses. At least one of the basic scan which is required for the contact lens is pachymetry and corneal topography. If these two is available at your facility, definitely do it and try to correlate with it. If these facilities are not available, then definitely send it to the nearest place where it can be done. And considering Mr. Jere's question, which Dr. Mumbi has asked, I think very soon Lusaka Eye Hospital is going to start a program which will start training in different specialization, because we as a hospital, we are trying to build optometrist with different specialization. Very soon, I think within 1 year or so, we can have a different specialization, which you don't have to go for out of Zambia to train your optometrist. You can train it locally, and that is what we want, so that we can give the best outcome to our patients in Zambia. Thank you.
Thank you so much, Mr. Bibek, for that presentation. I like the last quote. A second opinion is not a doubt. It's a commitment to give the best to the patient. Thank you so much. We'll quickly have our last presentation, and then we'll have a short Q&A, and then we'll call it a night. I know we are running out of time, but please bear with us.
Okay, good day once again. I'm not sure they can see my screen.
We can see them.
Okay,
But
great.
just put it on slide show.
Okay. Okay, is it better now?
Definitely.
All right, great. So good day once again. Thank you so much for this opportunity that I've been given. Thank you to the Zambia Ophthalmological Society, and also to specifically Dr. Mumbi for this, for inviting me to do this short presentation. So basically, I'll be talking about a study that was conducted in 2022, and we'll just be highlighting some of the key findings of that study. And then we'll also look at some of the gaps and opportunities that we have in Zambia in terms of refractive error correction services. So this study was titled Availability of Refractive Error Correction Services in Selected Zambian Hospitals, which was a cross-sectional study and also a quantitative study. So this study was actually part of another study that was talking about accessibility. Basically, to mean accessibility is not just isolated to availability, but we were using a concept to say accessibility involves availability, affordability, and geographical location. So it's not enough for services to be available. So as we know, the visual impairment is actually a major public health issue, and more than 80% of visual impairment is preventable. And refractive error is actually a leading cause of visual impairment, which we see very also limited in low and middle income countries. So this study that was conducted had the aim to assess availability of refractive error correction services in selected hospitals in Zambia. And it was a cross-sectional study conducted between October 2021 to March 2022. It involved 20 facilities in 8 provinces of Zambia. And basically these facilities were one site supported facilities, which at the time were about 35. But after we went through our inclusion and exclusion criteria, we remained with 20 facilities. We used stratified random sampling based on the different levels of care of these different facilities, and also the type of support that they had, whether they were government supported or government and faith-based supported facilities. We used a questionnaire to collect our data, and this questionnaire was sent online via email and other medias to our different facility managers. And the questionnaire was, first of all, based on the framework of accessibility to eye care services, and also the National Eye Health Strategic Plan, which also gave us guidance on how to adapt the questionnaire. So just highlight some of the findings of this particular study. So the facilities were 20 facilities, and both primary and secondary facilities. We didn't have any tertiary facilities at the time that met our inclusion criteria, so we only had primary and secondary facilities. So part of what we're looking at were just descriptive statistics of refractive error correction services in the study. And as you can see, we had some things that stood out. For example, the weekly number of patients. Most facilities had at least 10 to 20 patients a day, which was quite good. We also noted that patients didn't have to wait that long. Most patients waited for less than 30 minutes, which was also a positive thing that we looked at. And then the working hours for both working hours and working days per week were also quite positive. We had most facilities working up to 8 hours. Total human resource for eye health, we had some that had like only one, and we had some that had more than one eye health human resource. Then we also had, we also looked at outreach activities and the frequency of outreach activities, frequency of awareness programs and school-based screenings. And some of the things that stood out was the fact that only one facility actually conducted more than 5 outreach programs per year. We also looked at availability of equipment, and we're doing this in comparison to the National Eye Health Strategic Plan recommendations. And we noted that most facilities actually had equipment available. They just had a lack of probably more advanced equipment, like the, for example, the refractometer. We had some that had the equipment, even though that was not really a recommended equipment according to the National Eye Health Strategic Plan. We looked at the human resource for eye health, and one thing that stood out was we didn't have optometrists in the different facilities, but we had optometry technologists, and we had at least 10 facilities that noted to have optometry technologists. And then some of the challenges that were noted by the facility managers at the time, some of the things that stood out were that there were not enough spare parts for equipment. So you find that an equipment would be working properly, but then once it gets damaged, there was a challenge in getting spare parts to replace them. And then we also had insufficient space allocated to refractive services. For those that have probably gone around different facilities, we can note that the space that is allocated to refractive services is limited in some of the facilities. We also had lack of technicians to repair equipment. That was reported by 4 facilities. We had insufficient and lack of skill mix for human resource. And we also had delay in receiving spectacles, which was actually brought about by not having enough optical labs to dispense spectacles to their patients. And these are just some of the same key findings in terms of the waiting time and the fact that most facilities were accessible at good times, which was good for the patients. We had spectacle delivery delays for at least most facilities indicated that there was at least more than 2 weeks in spectacle delivery, and we also had limited school outreach programs. So the optometrists were insufficient in most facilities. In fact, we had no optometrists at the time of the study, but the facilities had indicated to have optometry technologists, which still helped to buffer and create more available services, refractive services to our patients. Equipment were also noted to be present, but insufficient in most of the facilities. And we had poor maintenance and infrastructure for refractive services. So these are just some of the percentages in terms of the challenges that were identified, which we already talked about. And then some of the strengths of our study were the fact that we had uniformity of study units. Like I mentioned, the facilities were one-site supported facilities. So they had, there was uniformity in terms of the characteristics of the study facilities. And then we also had minimized selection bias because we were collecting data from facilities that were already existing, a database of already existing facilities. And then also the study had internal validity in that it used guidance from the National Eye Health Strategic Plan and also from the framework of accessibility to eye health care services. Then some of the limitations of the study were that we had the lack of service user perspective, like was mentioned by the president, that our services need to be patient-centered care services. So that is one of the limitations that the study had. And in the future, I would like to do a study, actually plan on doing a study that can use more of the service user perspective. Then the other limitation were that the findings were based on just one-site supported facilities, which means that the study had internal validity, but perhaps not enough external validity. So the findings could not be wholly generalized to the other facilities that were not supported by one site. So some key takeaways is the fact that availability has improved. At the moment, one site has actually opened about 66 vision centers. At the time of the study, we had about 35. So today we have 66. It also has 11 private and 23 REXI facilities. We'd also say that the staffing levels have also improved. We've been actively training optometrists, both optometry technologists and bachelors in optometry until date. So I would also like to note that access is not equal to effective service delivery. So access is not enough. So we also need to look at how we can make sure that apart from services being accessible, they're also effective. And strengthening systems is critical, especially in eye healthcare services. So the gaps we identified are not just problems, they're actually strategic entry points for transforming eye health services in Zambia. So we'd like to note that when we look at gaps, these gaps actually present opportunities that we can use in becoming better and improving services, refractive error correction services. So some of the opportunities that we have is that we have strong partnerships. I think we can agree with that. We have great support from different partners, though we need to work towards becoming sustainable and reducing our dependence on the partners. Together, we can reduce visual impairment and make services more accessible. So we also have a good government commitment. The government is actively working on improving and expanding eye health services in the country. We have an improved data system and research, which is evidenced by the lab, for example, that we have that is supported by one site, which has a good data system that can be used for research, and that can help us to use that evidence to guide the planning that we can have for refractive error correction services. And then another opportunity we have is to create maybe better spectacle provision systems, given that there's a delay in the turnaround time between the time that patients have their eyes checked and when they receive the spectacles. We can actually create more units or develop more manufacturing units in the different districts that can help with improving this turnaround time. And then the other opportunity that we have is also knowing that we have an existing foundation of service. So instead of focusing on what we don't have, we can focus on what we actually have and see how do we improve what we have. So from the study, we're able to see that we have most facilities had the basic equipment. They may not have had the advanced equipment, but with what we have, the basic equipment that we have, they can actually be used to scale up and standardize our services. So in conclusion, we can say improving staffing, infrastructure, and service delivery is essential to achieve universal eye health coverage in Zambia. Thank you very much. And I've just included a link to the study for those that would like to read more about it. And also those are some references regarding what I was talking about. Thank you so much.
Okay, thank you so much. I have 2 minutes for questions, and then we'll close the meeting. Any questions for our 3 last presenters? I can't see any hands. I think people get okay. I'll choose the question. Yes, please go ahead.
This question is for Nikesh. Is there a cutoff? What is the cutoff usually, the age at which you stop myopia management? Say if you're using optical lenses for controlling myopia, at what age would you say you would go back to conventional lenses?
Yeah. So if mostly we are continuing till late teenage where we expect normal stabilization, probably 16 to 18, that's where we are looking at the age range. But still, if in 18 as well, if we are saying still it's progressing, then we are not stopping. The majorly studied clinical trials and all the studies which indicate till in the age group of 6 to 14 to 16 years, but still that we have seen the efficacy till 18, 19, and nowadays we are seeing adult myopia progression as well. So we continue till it stabilize at least 2 years, couple of years back to back, same reading in terms of axial length and refraction. We will continue.
Okay. And also, in terms of axial length measurement, obviously not every facility has that option. And a lot of the lens, optical lens solution, that the companies usually say that you can actually just use the refraction progression as evidence.
Yeah,
Is that sufficient, or is it definitely necessary to have axial length?
axial length is giving a better resolution, but IOMI guideline, as of now, they are also not indicating to start practicing axial length. But definitely, if you have axial length, it will be better to document. If you compare the changes in terms of axial length, like 100 micron changes progression, which correlates to 0.5 diopter, usually there are some thresholds which generally take time to progress or reflect in power change as well. So it's better to have axial length, and that should be non-contact biometry. Again, the resolution of contact and non-contact is different. If you go with non-contact, 100 micron, actually 20 to 30 micron resolution. If you go to the non-contact contact, then it will be 100 microns resolution, like that. So non-contact biometer, it will be better. If you don't have, you can't do anything. Probably you need to totally based on refractive error only.
I guess something is better than nothing, but more confidence
Yes.
with axial length.
Yes, definitely.
Great, thank you.
Yes, Dr. Mukti.
Yes, just a quick one also to Mikesh. I just wanted to find out what you'd recommend in terms of follow-ups for the patient who has progressive myopia. Like, how often do you have to see them? And then also, if you're going to do a scan for axial length, what's the frequency? For example, in a year, do you have to see them?
In a year, we will see twice generally. It's like 6 months plus 6 months. It depends on progression as well. If it is a rapid progressor, rapid means more than 0.20 mm changes in axial length and eyeball size changes, which we look for power wise. If it is 1 diopter close to, then we will probably call in 3-4 months. If it is not like that rapid, then 6 monthly follow-up usually we recommend.
Yes, and just a final one. So, what does it take? Could you just summarize for us, maybe in a resource limited setting, what it takes to start up a myopia clinic?
Probably you don't need any fancy things. So your simple retinoscope, with that you can. If you don't have if you have normal autorefractive as well, you can practice based on refractive error. Generally, just to rule out other forms of myopia. If you have regular autorefractive, you will get K readings as well in that. So you can definitely eliminate curvatural myopia on corneal surface. But lenticular, bit tricky. If you have biometer, if it is non-contact, that will be better. If it is not contact, most of the times contact is there to get that whether the myopia is axial in nature or not, that you can get, but you can't monitor with the contact biometry. Now you can do accommodative status, just like lag lead you can assess with retinoscope. You can do peripheral refraction. There are new instruments which are coming on, like trial frame mounted instruments to do peripheral diffraction as well. You can do with that help as well. So normally you can start with retinoscope. There is no fanciness like open field or something you need for peripheral diffraction. You need biometry. You can start based on refractive error as well. Just if you have extra further instrument, you will get better probably confidence. You'll get more resolutions, things like that.
Okay, thank you so much. If there are no other questions, is that a hand? Is there a hand? Okay, no, I can't see a hand. Okay, we are so grateful to our speakers for sparing time to come and impart knowledge and your expertise. We are so grateful. As we come to a close of this meeting, I'll ask Dr. Ngandwe, our ZOS Vice President, to give the closing remarks.
Thank you so much, Dr. Sampa, for having moderated this meeting so well. This has been quite a very informative CME that we've had for ZOS as well as the EXA region. On behalf of the ZOS President, Dr. Mumbi, I would like to thank sincerely all the presenters today for having prepared quite a great set of presentations. I'm sure all of us have come out of this meeting with great insights into what we see as sometimes things that we might end up taking for granted. We've learned quite a lot within the field of optometry, and it's hoped that as we go back to our clinics, we should be able to apply one or two things we've learned from this meeting today. It's also hoped that this meeting has enhanced our networks, as we have seen discussions that have been flowing. So we should be able to give each other calls and consult whenever we are in doubt. I'd like to thank each and every member, both locally, that is from Zambia, as well as in the EXA region, for having taken time. We were quite a good number in this CME. I think at our maximum, we reached more than 80, which is quite a very good number for a CME. And I pray that as we go forward, even with different meetings, you will be able to make yourselves available to attend. May I also, probably at this juncture, on behalf of the ZOS President, Dr. Mumbi again, say that we have quite a number of programs that we've lined up throughout this year, and we hope that people can attend. But one which is so specific and which will be coming soon is the first ever conference that we're going to hold as ZOS in the month of June, from the 18th to the 19th. This will be called ZAM Club, which is the Zambia contact lens practitioners workshop. So this will be the first workshop that will specifically be looking at contact lens practice within Zambia. And we're hoping that through the recommendation of that workshop, we should be able to standardize the care, the management of patients through contact lenses. And we are hoping that each and every member, each and every person who has attended today will be able to be in attendance then, so that we can share ideas and be able to come up with strong recommendations in that particular meeting. So it, like I said earlier, to be held on 18th to the 19th of June. And the first ever will be hosted by Lusaka Eye Hospital. And we're hoping that this will be an annual event, so that we can continue refining even the way we practice as far as correcting vision is concerned within Zambia, and probably the EXA region, as it were. Once again, may I just thank you all. I know we are all sacrificing our time right now. We've gone beyond the scheduled time that we had allocated for this meeting. But may I say thank you for your contributions and your attendance to this meeting. With those a few remarks, may I declare this meeting officially closed. Thank you.
Thank you so very much.
Thank you.
Thank you so much. Good night, everybody.
Good night.
Thank you, everyone, and good night. Thank you.